Okay, we'll go ahead and get started. Welcome. Good morning, everyone. Thanks for coming. We'll call the meeting to order. Approval of September 9th minutes meeting. Could I have a motion? Anybody get a chance or was here to read them? Motion by member Chantry, second by anyone? Second by member Foley. Comments or questions, additions? Hearing none, all in favor, please say aye. And opposed, and the motion's carried. Let's go ahead with our agenda items to be presented for information. Let's have a presentation and update on the Bridge Academy. Ms. Malott.
Yes.
Good morning. So I am not doing a full overview of Bridge and what our purpose is, since I know it's been presented to the group before. As a quick recap, we are serving adolescents in 7th through 12th grade who are at risk of hospitalization but experiencing internalizing mental health concerns. And they may have been exceeding what their referring school can support, or are returning from hospitalization, or exceeding a lot of crisis services. So right now we have 10 current students. We have one who starts on Monday, and we have 2 pending referrals. Our larger districts are still working through exactly who and how they're going to refer. They've had a lot of internal discussions about whether they're going to have students with IEPs or 504s in place before, which helps sets up and support the return to the school because it already has a team established. So there's some benefit to that, but our larger districts have not referred very many yet. So we still anticipate an influx of referrals in the near future, and they have started to pick up in the last week or so. So right now, our current and referred students are between 7th and 11th grades. One of the biggest pieces of success that I've seen so far is attendance. So it's one of the pieces of data that we're looking at. And when I looked at the average full day percentage of attendance for the 2021-2022 school year for our current students, that average percentage was 23% across all 10 students, which I'm going to also say was largely skewed by one student who had been at a RAS location previously and had the highest level of percentage of attendance before. So it was largely skewed by one student. And their attendance rates ranged from 0 to 68% before they came to us. Currently, and this was through Tuesday is when I calculated it. So currently their average attendance is at 66% across all 10, with a range from 25% up to 100%. And the median is 73. So most of our students are coming almost every single day, and most of their absences have been physical illness. We have a number of students who had not made it through an entire full day of school for at least the semester before they came to us, who have made it the full day every single day that they have not been physically ill. And they can acknowledge that they've had support to work through that and they've made it the entire day. So that's a win. All of our students have completed a GAD-7 and a PHQ to assess for mental health concerns in a variety of areas when they come in. And that then guides and shapes part of their individual success plans. So we have goals and objectives tied to those, as well as attendance and academic goals tied to observations by our teachers. And so their academic goals may not be achieving a certain grade in a class, but instead that they will verbally participate or that they will put forth effort. So all of our students have sort of an initial attendance goal and then an attendance goal in order to consider a successful transition back to their referring school. And in part, we also want to set them up for success. So we want them to have a successful return, but we also want them to know that there's a step before that possible higher threshold and that a win can come before that. So a lot of them also have stepped goals. Okay. The other thing that I brought, so we had a day this week where most of our junior high students were physically sick, and we only had one. And that individual student had completed their science project already. And so I gave their teacher the option to present to them an opportunity to write something to include in the newsletter that we're sending out to parents and superintendents. And so I thought I would bring it to share because it highlights, and I will say, this is a student who previously had not made it through full days at school and has never once had to have a parent called to come pick them up, has only missed due to physical illness, and it's cool. So what this student wrote was, my experience at Bridge Academy has been a positive one. Being here at Bridge has helped me through a lot, and I can tell I'm on the path to becoming the best me I can be. Bridge Academy has many supportive staff members and students. Bridge Academy has been like another family since I have been here. I've had my ups and downs here, but I have seen that no matter what, someone here will be there for me. I have observed that here the students and staff are there for each other and help out when needed. Bridge is much different than a regular school, and I think that's good. They focus on not only academics, but your mental well-being. I don't think there's anything I would change about this school. They have an amazing way of doing things, and it has helped me overall. So today marks the end of our 4th week of classes. So most of our students have also made it a full month because most of them started on day 1. But that's a little bit about where we're at right now. At our 30-day point for each student, we'll be reassessing the GAD and the PHQ to also determine whether we need to reestablish any new goals for the students, if anything new has arisen. We have seen some increases in anxiety, in part because they are constantly having to deal with what was previously a trigger for them. So simply by showing up, it's anxiety provoking, but they're also learning ways to reduce that some during the day and to prove to themselves that they can make it through even when that arises. So.
Any questions?
I have one question. Looking to the future, what do you think the capacity will be for Bridge Academy in the next year or two with the current staffing model?
So with the current staffing model, I have said that I think we could probably go up to a total of 36 students. We had intended to keep our student to staff ratio at 10-1. And I think it's all going to depend on the dynamic of the students and their level of need. I do think that we could accommodate up to 12 in a classroom pretty easily. We are hoping to hire a 4th teacher still, but are very intentional about what that 4th teacher will bring with them in terms of credentials and experience. So it's still our plan to hire that 4th teacher to increase our capacity further.
Thank you.
Diane?
It's really hard for me to not tear up listening to this. And I just, it's a big step for our county. You know, I just want to reiterate, given that we have a program that serves high-need kids, this is in no way a competitive environment. These kids are a unique niche group of kids that have been underserved for so long, and this program, if it's like anything we ever developed to meet an unmet need, be thinking, and it sounds like you are, Trish, the demand for this is gonna come out of the woodwork. You know, success is gonna build success as these bigger districts get their referring protocols. So plan early and proactively about how we're gonna be able to scale this up, because the demand is probably going to shock you once it really gets going, and then you're scurrying trying to figure out how you can meet that need. But just kudos to you all and everybody that pooled funds and helped make this happen, because it's a big step forward.
Thank you. Any other comments? Sonia?
I really appreciate this report. can you help us think about how we prepare teachers for this very special area? Because you said you're going to be looking for a fourth teacher. You're going to be very deliberate about what it is. So what do we need to address in our education of teachers?
Oh, Sonia, I'm not sure there's time for me to get on that one.
Are we engaging in a conversation with ISU that prepares a whole lot of teachers about this?
So one, I think what you're asking and addressing points toward another piece of big systemic change that needs to occur beyond just local teachers and local educator like prep programs. Because what is true, and I think all of us in this room know this, is that our teachers, as they go through their programs in college, they are taught how to teach, and they are taught content relative to what they're planning to teach. They are not inherently always taught about how to address student mental health or what happens when a student has a crisis, or how students cope that may look different than adults. And so there are a lot of aspects that don't arise in that, and I think that's a bigger systemic need. Do I personally feel really strongly about that? Yes. I do think, so some of the things more locally, I think pushing mental health first aid for youth and having school staff and educators go through that is a big piece of what can help. We had all of our staff do it and invited, I mean, there wasn't a lot of notice because we had initially only planned to do it for our staff, but we did open it up to other folks in the region if they wanted to come that day. So pushing youth mental health first aid, I think is important. I think it's one way to help teachers prepare. We do eventually hope to be able to bring student teachers in and also have co-teaching models for periods of time with existing teachers so that they can learn part of what we're doing and see our approach and then take it back to their districts, but that's not an immediate step. It is in our line of goals, but we really focused on getting off the ground, making sure that we're doing it right and we're meeting our own goals before we start inviting everybody else in. So one day.
Thank you.
Right side, sorry. Thank you, Mr. Chairman. I just wanted to make a comment that we will provide opportunities for this group in small groups to come and see the program. A real formal open house, honestly, isn't going to probably occur until second semester in terms of the building. Mark First is still in transition coming into the building, and obviously they're the biggest occupier of that. So, but we're very cognizant of the interest, and so as we get settled in, we'll kind of send out small invitations for small groups to come and see what we're doing and see the space.
Is there anything we can do to help as far as any slowdown as far as anyone, larger districts or so on, that, are they just going through the process or to refer?
They're going through the process, so they've actually reached out to us for some clarifying questions and things like that. So it's as much, honestly, them working through some of their internal processes to support some of the kids with more significant IEP needs, and they may have to provide some of those supports, which is not unusual when they're going out to outside programs.
You see the
So-
school social workers and counselors carry their big pile of IEPs around, and they get me to sit in because I always needed somebody from the staff. Stephanie, you had a question?
I do actually. I have a kind of a two-part question. First of all, I mean, it sounds like you're really only approaching that first 30-day mark so that you're going to be reassessing those youth at this point. What is your anticipated kind of length of stay or length of time that you view these kids being in Bridge Academy? But also then, can you speak a little bit to how Bridge Academy is working to connect kids with outside community providers so that when they do move back to the school, there's a team around them that way?
So The first part of your question, I have no idea, is my honest answer. So we set a minimum amount of time being 60 days, knowing that sooner than that really would not be enough time for students to get acclimated, to start to feel supported, to start to move towards success. Given our current students, I don't anticipate that any of them start to return to their referring school at around day 60. They've all shown improvement, but I don't know that any of them are going to be ready to return at day 60. So I don't have a sense of when they'll return. I do know that, especially for our larger districts, their preference is for students to return at a semester break point. So we will take that into account as well. And the districts also know that if we believe that a student may not successfully return if we wait too long, that we will advocate on behalf of the student and we'll work with the district about what that transition plan may look like, and it may just be a longer transition. But I don't currently have a good answer for how long they may be with us. Connecting to outside resources is one of the things that we intend to do, is to make sure that they do all have outside resources. Many of them came in already connected, at minimum, to SAS. I'm sure that's not surprising. So at minimum, most of them have had connections to SAS. Many of them have an established relationship with a prescriber. Several of them have existing therapeutic relationships with someone, and they are receiving therapy like in the school setting as well. But we do know that some of them have a need for outside support. We do know that some of them have a need for some family services. We also have some parents who it would really be a struggle to, not necessarily to get them to engage, but to get them to be able to engage in a service or get their child somewhere during certain hours where other places are open. And so the same hurdles that are encountered in lots of settings are encountered here too. And then we have a few students who are really just reluctant to engage in outside services, and getting them to come to Bridge was a really big deal and a big step, because they had refused school for years. They won't see a psychiatrist. They won't go to therapy. But they will come to our school and they meet with their case manager and they meet with a therapist and they participate. And that's a good first step. So we will be making referrals and making connections based on individual need, and also taking into consideration family insurance and where they're living and hours that they might be able to participate.
So does that mean that a good number of them are Medicaid eligible youth?
Yes, yes.
I asked if a good number of the youth currently enrolled are Medicaid eligible youth. Oh, sorry. I said I simply asked if a good number of the youth enrolled are currently Medicaid eligible youth.
Any other questions?
Just
Colin?
oh, go
Go
ahead.
ahead.
I'm sorry.
My question is quick. I'm wondering if we know parents whose children are struggling in their school who may be a good candidate, what would be the best way for them to move forward? Would it be reaching out to Bridge directly, or would it be communicating with their school that they're currently in about options?
So my recommendation would be that they connect with their school, since the school is who would have to make the referral. And while I've had parents who reach out before they've discussed the option with their school, and I will answer their questions and I talk to them about the program, but I also make sure that they know that the process has to originate with the school that their child is either currently enrolled in or would be if their child were enrolled in school, and that we can't accept them without that district referral. And so that's part of the process. So from my perspective, I generally don't want to circumvent the district and their process, and so I try to refer them back that way, so.
On the transition with kids back you know, to the public school. That family component and that family support piece is so critically important. You know, I will frankly say at Hammett that we will see more anxiety from the family about a kid moving back to the public school than we even will see from the student. The parent is so relieved that their kids' needs are getting met, that their child is being successful, that the parents aren't getting calls from the district, and the family gets so anxious about that whole cycle of failure and disruption to the family starting all over again when that kid goes back. So those wraparound services, all of those pieces are going to be an important part of that transition. And the last thing related to the training question, I think in the grant that we submitted to SAMHSA that we didn't get, there were some aspects that were addressing the capacity of our community to scale up training for professionals across the board that are serving kids in different settings. And, you know, I hope that that will be an area particularly focused on serving children and youth, that our BHCC group or whatever forum's appropriate, we have a huge capacity among different providers to do training, and the ability to just organize it and help support some of the cost associated with that could really help elevate and support multiple programs in the community. So we've got a capacity there. We could just maximize it or leverage it better if we can get it organized. And it might be a good thing for United Way to think about for future funding needs. But anyway, just saying, you know.
Hint, hint, nudge, nudge, know what I mean?
Okay, anyone else? Kevin?
Thank you. This is great to get this update. A little bit more, I guess, on the current teaching staff. And can you share with us kind of what that profile looks like? Is this social workers? Is this special ed teachers? Is this dual credited folks? Who are you currently? And then what does that forebode for some of the programs in the pipeline?
So our therapist is an LCPC, a licensed clinical professional counselor, who has had years of experience with students in the school environment and outreach and is already known to most of the schools. We have two case managers. One is a social worker. One actually has her undergraduate degree in math, but spent years in the guidance office at one of our junior highs and facilitated some of their healing circles and different things. So she brought a lot of experience with her. Our teaching staff, we have one who most recently was a teaching assistant at Hammett, and now has their own classroom, but had previously taught high school physics in a public school when they were first done with their undergrad. We have another teacher who has largely taught junior high for the majority of her career, and so she is the junior high homeroom teacher. But she also teaches our STEM work. And then we have a special ed teacher as well, who is currently teaching humanities and addressing any of the resource time or additional special ed supports for the students with IEPs. So. Mm-hmm.
I want to say this, being a former counselor, some of your best teachers are also some of your best counselors as well. So there's obviously that changeover. Hope I didn't put down any counselors, any of my colleagues, when I said that. Anything else you have? Okay, I'm sorry. Sonia?
While we're on this whole topic of teachers, I'm looking around our room and saying,
Turned it off. Okay. While we're talking about teachers, and I look around the room, and I'm wondering, in our makeup of this group, do we have intentions to get somebody who is, or several somebodies from education in our two major school districts at this table to hear these conversations. Just a thought. If we want them to be engaged and understand all this area.
Sounds good. We'll
He's
consider it.
here
We'll
for
hang on to that
education, I
thought.
know that. But he's not in a classroom.
You will be, if you're thinking of an active teacher, you'll be challenged to get one for these meetings. Just matter of fact. Yeah, because they're in class right now. And subs are really hard to come by, especially on a Friday.
You need them in the classroom too?
Okay, thank you. Thanks, Tricia. Let's go on to item B. Stephanie, we're back to you, Pathways to Success Program.
Fabulous. Well, thank you, everybody. And Tricia, actually, if you haven't grabbed a packet, maybe we can connect because I think there might be opportunities. That sounds fantastic. So, Kevin, do you have a clicker? Do you want me to?
He's got the PowerPoint loaded up back there. You can just say slide, or what are the other alternatives?
Okay. All right. So thank you, everybody, for the time. What I plan to do this morning is kind of share an overview of the new Pathways to Success program that the state of Illinois is launching for youth with complex behavioral needs. So it fits right into the conversation that we've been having. For those of you who, follow some of the legalities and things that have been happening, the Pathways to Success program is the response to a lawsuit called NB that was against the state of Illinois for not having a robust system of care for youth with complex mental health needs. And so out of the NB lawsuit, of course, comes the implementation plan, and this is the state's plan to address those needs. Go ahead, slide, please. Thank you. So it is a program for youth who are Medicaid eligible. That's important distinction. With complex behavioral health challenges. And what I mean by that is youth who are struggling with symptoms or behaviors that are impacting multiple areas of functioning. So school and home, impact with the law and justice system and school. So generally having more than one area in which they're struggling. You notice that the launch date says March 1st, 2022. That is clearly not correct. The state had some challenges getting federal CMS to approve the plan. So the plan was finally approved in July of 2022, and the anticipated go-live date is January 1, 2023. So it's built upon intensive care coordination and wraparound models that are to help coordinate the care of youth and has the potential to bring new services to the arena. And that's actually part of where I'm here today, is to help recruit some people and get them thinking. It is guided upon system of care principles that put children and families at the center of planning for their own services and needs. And it is community-based at times that are available for families, right? Times it's convenient for them. The services are also designed to be where it is convenient for them. Homes, schools, community, et cetera. And as I mentioned, it has to do with the NB consent decree. Slide, thank you. So this is just a note of the various different principles that fall under system of care, right? Culturally humble, youth guided and family driven. It is team-based work. It is community-based and collaborative. And then it is data and outcome driven. Slide, please. So the key around systems of care models is that families and youth have leadership in not only their own case, but in the model altogether and the services that occur. So there are specific strategies for mentoring and training. There is potential support and participation in family leadership councils for families. And then there's specific strategies for evaluating their engagement in the process and outcome. So what does success look for children and families? And so I'm going to also apologize slightly that I borrowed all of these slides from the state, so they're not mine. But really, we're talking about helping children and families and youth up to age 21 function better, right? So function better together within their family, and their caregivers having less stress, their living conditions being stable, and youth having fewer reasons to be pulled out of the home, right? So fewer hospitalizations, fewer needs for youth to go into residential treatment or foster care even at times. And increased family and youth involvement, because if they're driving treatment, the hope is that they're engaging more and involved more in that. The use of evidence-based practices and models, improved school attendance and performance, and then reducing contacts with law enforcement and child welfare, as well as the emergency response team and crisis response teams. That's another piece to this. Slide, please. Thank you. So to be eligible for Pathways to Success, a youth must be Medicaid eligible, under the age of 21. It states have a serious emotional disturbance or a serious mental illness. Those are specific categories in which DSM diagnoses fall. However, that has changed a bit since this slide was created by HFS. They are actually going to be utilizing only the IMCANS, which is the state's mandated assessment and treatment planning tool, to assess whether or not youth become eligible for pathways. So they have an algorithm that's being developed. Slide, please. So for those of you that may not know, the IMCANS is a lovely tool.
In the state's ultimate wisdom.
So it stands for Illinois Medicaid Comprehensive Assessment of Needs and Strengths. And it is a communicometric tool that helps rate students and youth on, or adults as well, on various areas. So whether it be symptoms or functioning or risk factors or strengths. And then those ratings are to be utilized to develop a treatment plan. And so the state's vision here is that the IMCANS will be a single document per consumer, that all providers who are providing services to that consumer will be working off of. So a single treatment plan that is coordinated and includes all of the services and treatments and supports that these youth and family may need. I won't go through the rest of that. Yes, slide. So in terms of the decision support criteria, HFS assures us that they will be sharing that support criteria so that we understand the algorithm, but they have not yet done that. However, how this will work is that youth who are served by a Medicaid provider have an IMCANS completed at the beginning of their treatment. That is the assessment and treatment plan process. Those IMCANS, by all of us who do that work, are submitted to what's called the IMCANS portal. So there is a centralized portal that all IMCANS are uploaded into, at which time the state will apply the algorithm to all submitted IMCANS monthly. And youth who become eligible for pathways under that IMCANS will be grouped into one of two tiers. Tier 1 is the highest need tier, and that's high fidelity wraparound. And Tier 2 is a kind of a step down from that called intensive care coordination. And the services then that become available to youth enrolled in pathways, and I'll speak more to those, then are available. Care coordination is available in those tiers. The rest of the services are available to the entire eligible group. Slide. So I kind of already went through this. After youth are stratified, after that algorithm is run on the IMCANS, the family will receive a letter. Eligibility is automatically given in 6-month increments, because that is how long the IMCANS is a valid assessment and treatment plan. So 6 months of eligibility, and then those youth will be assigned to a care coordination and support organization. And those organizations are responsible for the care coordination and mobile crisis response services for Pathways eligible youth and all Medicaid eligible youth. And that is the role that CYFS will be playing. We are going to be, the CCSO and the SAS provider. They call it mobile crisis response, which is why I still call it SAS. So there's some definition here. And so that is the role we will play. We will be notified that we have youth who are eligible, and then we will be reaching out and doing some other things. And again, 6-month eligibility. So every IMCANS update, every 6 months, the algorithm will be run again. And if the youth remains eligible, they will remain in Pathways. If the youth is no longer eligible, they will be transitioned out of Pathways. It is also possible for youth to move between the tiers. So a youth may come in as Tier 1 high fidelity wraparound, and at an IMCANS update may not be as severe, but may still require Pathways or be eligible for Pathways and be moved into Tier 2. It can happen the other way as well. If you have a youth who may originally stratify as Tier 2, but have a crisis event, there's an updated IMCANS, it may lead to being moved up to Tier 1. Slide, please. So these are the services that are available under Pathways to Success for those youth who are enrolled and eligible. I've already mentioned care coordination and support. That is the wraparound services that CYFS will be playing. Family peer support. So this is a service that is designed to be provided by parents, someone with lived experience, caring for youth with mental health issues who have had to navigate the system before and can really help families through that process. Intensive home-based services, which is a specific treatment model program. Respite, and in terms of respite, it is less than 24 hours. Like there's a maximum, whereas those of us that work in child welfare, we think of respite as overnight. So there is a distinction there in that service. Therapeutic mentoring, and then therapeutic support services and individual support services. Slide, please. So the role for the care coordination and service support organizations. Locally, we are the CCSO for what is known as Designated Service Area 12. That is Livingston, McLean, and DeWitt counties. So technically, we are the entity responsible for the SAS, Mobile Crisis Response for Medicaid eligible youth, for all 3 counties, and then for the care coordination part of Pathways for all 3 counties. What we have done in our designated service area is we have partnered with the local providers that are already providing that mobile crisis and SAS response in DeWitt and Livingston, so that they will maintain those areas and the SAS relationships and experiences they already have. And we have maintained our partnership with McLean County Center for Human Services to be the primary mobile crisis response provider for adults here in McLean County. So the key functions are providing the care coordination, serving as the care coordination entity for 2 programs called Family Support Program and Specialized Family Support Program, which are small niche programs that we already are responsible for as the SAS entity. We are responsible to operate as the fiscal agent for the dollars that are available under the individual support services and therapeutic support services. And then, as I mentioned, we are the designated mobile crisis provider for HFS, so SAS provider. Other activities that we are responsible for are engagement and outreach, child and family team facilitation. The care coordination entity becomes responsible for the IMCANS.
Well, they ought to pay you extra money for that, Stephanie.
I agree with you. And if you'd like to write a letter to your state representatives, I can provide you with some information. Coordinating and providing consultation, referrals, resources, linkage, you name it. When it comes to coordination, that is the role of our program in this respect. Next slide, please. So just a brief outline of the things that families can expect from us, right? So listening to them, right? Most of these are just basic social work values. Listening to them, helping the family create a crisis prevention and safety plan, really in advance of a crisis, hopefully, right? So creating a plan as early as possible with what are the kinds of situations that are challenging for you and your family? How can you respond? What are your supports? And then making sure they know when and how to engage mobile crisis response versus going directly to an emergency department or calling 911. Really trying to get the community piece of those things, that crisis response, back into the system. Helping the family, really building a child and family team with the family. And then holding those child and family teams regularly. And by regularly, high fidelity wraparound requires full child and family team meetings with an IMCANS update monthly. And the intensive care coordination is every other month. So it's intensive. Helping the family and really building partnerships and coordinating with other providers and other supports and other types of child-serving entities, not just treatment, but recreation, childcare, like anything you can really think of, and then working with the family to really update. So there is a lot of carryover for those of you that kind of heard the CAT team plan and how that runs. There's a lot of commonalities here. And so there may be the ability in some respects for youth who are connected through CAT or through law enforcement to potentially qualify under pathways rather than being served directly by CAT. Next slide, please. So this is just kind of speaking a little bit to those different levels of wraparound and care coordination. The concept being the right amount of support at the right time. Next slide, please. So for those of you that aren't familiar with what a child and family team is, it is a defined group of people that are brought together to help support a youth and their family. And so it can include both formal supports, so an individual from the school system, a therapist if they're already engaged in therapy with someone, but it can also include natural supports. So it could include grandma or a neighbor or a coach of a community league of some kind, individuals that the family wants included in their child and family team. The team is defined by the youth and family, not by the care coordinator. The only people that are absolutely required to be a part of the child and family team is the care coordinator and the child and the family. And then there's some expectations if a youth is receiving or has had a mobile crisis event, that provider be engaged as well for a brief time period. And that team is where the IMCANS is reviewed and updated, and the treatment plan is really created as a team. Next, please. So these are some of the other kinds of things around that plan of care that we will be looking at, right? So historically, behavioral health services were pretty much, behavioral health services, right? So we're looking more at that holistic need of the youth and family, everything from, do they have a primary care or a pediatrician? Are they getting their checkups? Do they have transportation needs? Do they have housing or utility challenges? Things like that are really going to impact the stability of the family. Next, please. Again, these are those additional services that become available under pathways. Something to note is under federal CMS rules and regulations, the care coordination entity is not supposed to be the provider of these other services, right? There's a non-compete concept. So the idea being one agency is the care coordination entity, and these other services have to be provided by somebody else. And so that's where I'm like, I'm kind of here to recruit. Please be thinking. Because we're going to be that care coordination entity, and we would really like the whole system of care to be robust. Next slide, please. So family peer support, as I mentioned, provides direct support to the caregivers. It's a parent or someone with lived experience who has cared for a child with complex behavioral health needs. Somebody who's navigated the system and can be like, I've been there. I know where you're coming from. Let me help you. Next slide, please. So these are some of the key activities that HFS outlines for them is really supporting the family, helping them understand how the system works, advocating for them, encouraging that the parents are taking care of themselves and engaging with providers, both for their youth and maybe if they need their own, and modeling collaboration and even potentially some skill building, some parenting education, some coping skill communication education, those kinds of things. Intensive home-based services, as I mentioned, this is a model of treatment that is a team-based model that specifically utilizes a system called MAP, Managing and Adapting Practice. It is designed to be intensive, short-term, and to be provided in the home, and about how to help the parent and the youth develop the skills needed so that that youth can remain in the home and stabilize. Next slide, please. So it is consistent, as I mentioned, with MAP, Managing and Adapting Practice, to be as brief as possible, is a common elements model. So we've all heard of evidence-based practices. There's a lot of them, and there's a clearinghouse. What MAP does is that it looks at the commonalities across those evidence-based models and pulls out the techniques, the therapeutic techniques that are in those models, and says for something like anxiety, all of these models use exposure therapy. So exposure therapy is a recommended treatment modality. It's a therapeutic technique for anxiety. And so rather than being beholden to a single evidence-based model, it allows for flexibility across the evidence-based models for youth who have complex needs. Partially because most truly evidence-based models are single-issue models. They treat trauma, they treat anxiety, they treat anger management. These youth have more than one thing, and so a single model wouldn't work. Common Elements allows the flexibility to still utilize evidence-informed practices, but in a way that is individualized to that youth and family. And it has two pieces. So it has the clinical piece and the support piece, and it's designed to be provided by a team of a therapist and a paraprofessional, whether that be a bachelor's level staff or someone who's not operating as a therapist. Next, please. So a little more specifics here on those things. It is really about symptom reduction and improving family functioning. It is key to the MAP model, and so it can be provided in coordination with another therapist that may be involved with the family longer term. It is not necessarily a replacement, but it also can be if that's what the family would decide to do. Next, please. So therapeutic mentoring is the provision of mentors for these kids, right? It is a mentoring relationship that allows people to spend quality time with these kids, modeling positive interactions, and working with their mentors on developing really key skills, right? Social skills, communication skills, some of those things that really are done best in the community, right? Taking them to eat and teaching them how to order and how to use manners, like those kinds of things can really be helpful. Next, please. And so this actually allows trained mentors, so there is some training required, but it isn't designed to be therapy. It isn't designed to be intensive. For those of you who have been around for a while and may remember what the individual care grant or ICG program used to look like, this is kind of going back to the model that we had at that point in time, where we had individuals with training and exposure to key things about the youth we were serving, they could literally just take these kids out and go miniature golfing, right? Could take them to a ball game, could take them to karate class and do the class with them. And that way, if the youth had a challenge, there was somebody present who could kind of help them through that, but teaching them how to do those things while they're doing these other kinds of things. Next slide. So respite, as I mentioned, this is a planned short break. It is not overnight, but really the idea is to give parents a break. Give them some time. One of the things that we often hear from our families with youth that have more challenging needs is how guilty they feel because they spend so much time focused on the youth that's identified as the one having challenges that they don't feel like they're able to meet the needs of their other kids, right? They don't feel like they can spend quality time with their other kids or even with their paramour or spouse. Like, we don't have any time together because I'm constantly dealing with Johnny. And so this allows parents and caregivers to really have a break. Someone else is caring for their child for a few hours. So there's, distance, a little bit of separation, and a little bit of time for those parents to kind of come back and ground and regroup. So as I mentioned, it's time limited. It is primarily designed to be more of an individual basis, but they will allow this service to be provided to up to 3 kids in the same home. So if you've got a parent who's really struggling and just needs time alone, or needs to be able to go to the grocery store without their kid throwing a tantrum, like, that's really what this is for, is that parent support, even though the service is with the kid, but it's primarily. So next, please. So therapeutic and individual support services, as I mentioned earlier, as the care coordination entity, we will be responsible for being the fiscal agent for these funds. These are basically flex funds. Each youth who qualifies for pathways and enrolls becomes eligible for a pot of money for therapeutic needs and a pot of money for individual support needs that can be spent on either specialized therapy, so things like equine therapy or art therapy or sexual offender therapy or sexual problematic behavior therapy, models that aren't currently available generally under Medicaid, right? So if a provider can bill Medicaid, that is the expectation, or an MCO. But if it's a specialty need that a youth has and they're not able to bill Medicaid for that service, that's what the therapeutic funds are for. The individual support services dollars, and you can go ahead and thank you, are more about recreation. It's about wellness. It's about getting kids involved in things and parents involved in things that are going to be helpful to supporting that family, to supporting that youth, but really aren't treatment. They're more adjunct supports. And for those of you that may be aware of the Family Support Program, this actually matches what youth become eligible for under the Family Support Program as well. Slide, please. Thank you. So as I already mentioned, as the CCSO, and across the state, there are CCSOs everywhere, we become responsible for leading and coordinating the IMCANs, for developing it, for uploading it to the portal, for disseminating it to the youth, family, and all providers that will be working off of it, and then updating it as well. Next, please. We are also required to coordinate the community as a whole, right? So there's requirements that we have a stakeholder council and that a community resource directory has been developed. I will say that we are, as usual, ahead of the game here. Our CAT team already has a stakeholder group here in McLean County. Livingston County also has a stakeholder group that had been convening. I believe it still is. Mark, you might know more than me. Okay. And so really we'll be focusing on bringing pathways to those groups and including them in that piece, and then also building that into WIT. And We are incredibly lucky with Path in our backyard that we already have a very large community resource directory. So that is the primary one that we will be using, but we will be creating our own, looking more at things like those wellness and recreation and specialized therapies that may not currently exist in Path's directory. And then we will be, relying on all of you guys to partner with us, to be, be at the table, be talking with us about how it's going, about how we can partner better, and any of the other collaborators kind of listed there. Next, please. We are also required to collaborate with the managed care organizations. As you know, a good majority of youth who are eligible for Medicaid are being managed by these managed care organizations, so they will have care managers that will also be part of the child and family team. They will also be possible in terms of helping find treatment providers. So that's one of the benefits of an MCO is they are the credentialing and insurers. So if we need a specialty treatment that is not available, we can help tag them in to say, please help find something. Next, please. And that might be it. So I know that was a whole lot of information, and there will be more, I'm sure, but I wanted you guys to know what was coming. Any questions?
Who wants to start?
Well, Sonia's light was on, so.
Let me back up and
Okay.
ask a very simple question. There's a whole lot of people required to be in there.
There's a
involved with
whole
that,
lot of people.
to try to coordinate. Who writes the single treatment plan?
We do.
With input from all the others?
Absolutely. They are done in coordination in the child and family team meeting. So everyone that the family has at the table has a voice to that. And then if there are providers that are engaged that are not at the table, as long as we have a consent to do so, we will be engaging those providers to be certain that what they need is also in that plan.
Is this all Medicaid eligible?
Yes.
Anyone else have a question? Sonia?
Okay.
And, go ahead.
I have a couple comments and questions. So I appreciate all the effort that was put into a very deliberate process for this. I noted that it does meet a couple of the recommendations that we had in our mental health action plan related to peer supports for youth, but also a comprehensive wraparound service. I also appreciated that you mentioned the intersect with CAT. I was thinking as you were going through some of the original first slides, how that might be related or compete. And so I'm happy to hear that it is more of a coordination or a transition and can be utilized with that same group, because I know there are a lot of dedicated people on the CAT team. And, you don't want to burn out those same people that go from meeting to meeting to meeting.
Absolutely.
So I was happy to hear that. So my question is, if this is a grant through the state, how is that funding stream provided?
Sure. It is not a grant. It is a per diem. So the care coordination entities for the care coordination services will be paid a per member per month rate.
Okay. Very good.
Where's the money coming from in the state?
HFS. It's HFS.
Okay. Anyone else?
Stephanie, what are you anticipating for DCFS youth in care that are in like traditional or home
Sure.
of relative settings where their mental health needs obviously are sometimes underserved? And I
Absolutely.
mean,
Yep.
just talk a little bit about that if you could.
I absolutely can. So youth in care are eligible for pathways. However, at this point in time, because the coordination between child welfare and the care coordinator and how that will look with things like Family First,
Right.
DCFS is at this point in time asking that youth not be assigned to pathways until they can work out the details. And I see your look, but I'm actually going to say that I agree with it. I sit on a lot of stakeholder committees, and I also chair the CWAC SOC committee where most of this work has been talked about. And when it comes to how this would interact with DCFS. If you recall choices,
I was gonna say.
as
not-
the pilot.
Not known to play nice in the sandbox with others
Well,
sometimes.
and the challenge, so Choices was a pilot that was run in the four-county Champaign, Vermilion, Ford, and Iroquois County area. Choices was actually the managed care organization that was responsible as well for care coordination. And so really it was the state's trial for something like Pathways. For youth who were community-based, not engaged, not youth in care, not in child welfare, it was very successful. It brought child and family teaming, it brought an array of services and dollars, really dollars for these kids to be able to experience things that they really can't otherwise experience. But the care coordination entity was also the managed care entity. So there was some desire to save costs, right? Where we saw the biggest challenge in Choices was with child welfare. There was a lot of role challenges, a lot of role confusion, a lot of who has final say, also who does what. And so one of the things that we wanted to work on, and DCFS agreed and has moved in this direction, is ensuring that between DCFS and HFS, those understandings are very clear. The roles are very clear. What does the child welfare caseworker do? What does the care coordinator do? What does the youth care coordinator do? Because there ends up being a lot of people at the table who all have a stake. And so they've put a pause on it. Now, they anticipate that youth in care will be added to the list of youth who become eligible in the spring. What they are truly questioning is the role with residential treatment because of Family First, and then that brings its own set of guidelines, and too many cooks sometimes.
Diane,
make
didn't
things.
your organization provide service over in Champaign County?
Yeah, and, you know, we were part of collaborating with the Choices project.
So were we.
But.
What was
but
your
it-
take on it?
Yeah, you know, I think Stephanie's described it well. It was a pilot. I think there were aspects of it that did provide support to kids and families that were underserved. And then the role clarification, you know.
Yeah.
And I think there wasn't a period to really cultivate partnership either that made it more challenging. But Stephanie, do you know by chance who has the Pathways role in Champaign County?
I believe it's Rosecrans.
Okay.
Yeah.
I was hoping maybe your geography was going to include Champaign County because I know you guys are very active in that geography as well.
Yeah. Well, and there are some areas that are currently uncovered by a care coordination entity because nobody applied, and I have been approached about building in those areas. But we're talking about a number of staff in an incredibly challenging workforce environment. So I'm trying to develop this team right now with PATH also still building up 988 with, you know, lots of things happening and drawing from the same work pool. So in terms of being in other areas, what we've agreed to do is to start here, and then we will reassess as we get kind of stable.
Okay, thank you. Susan?
Yeah, I have, to go back to the IM cans, and I know we've had this little conversation, but one of the things that this group and some of the things in the Mental Health Action Plan is talking about data sharing and information sharing type activities. And so when you're talking about the IM cans being uploaded into the portal, yet other providers may be providing services, are they going to have access to that and then be able to bill off of that? Because I know that that's been an issue, and I don't know where that's at right now. Thank you.
So, yes, another entity that is providing services to a particular individual, if there is already an IM cans in place, can access that within the portal if they have a release of information to HFS. However, as the care coordination entity, we are required to get releases to all of the engaged people, and we will be disseminating those IM cans to those providers. The challenge, and I don't want to get too far in the weeds, but one of the challenges is there is no two-way communication with the portal. So those of us who utilize an electronic record system, the IM cans is built into our electronic record system. Everything runs off of that electronic record system. There's no way to import that information. But that's a larger issue than pathways.
Thank you very much.
Thank you.
Let's go ahead and move on to item C, Safety Act information. Judge Foley.
Yeah, thank you. This will be fairly brief, and it really is a request. Some of you may have already received an information through Kevin, and I appreciate that, Kevin. As you all know, the Illinois legislature passed legislation last year. It's got all sorts of names: the Safety Act, the Pretrial Fairness Act. Parts of it have been implemented as of this summer, and then the biggie, the no cash bail, goes into effect January 1. Our criminal justice partners have been meeting regularly to discuss implementation of the act, and one thing that's come out of it is that the officers on the street in this community really need an updated resource. If they're not going to be taking someone to the jail, where can they go? Bloomington Police Department has a great little booklet that they've provided to me, and I've offered with my interns' assistants to update. And it's really not so much, they know what the services are in the community. They really need to know what the exclusions are, because if they get someone at the door and they'll go, oh, nope, we can't deal with that, then they have to go to Plan B. So don't be surprised if you get, if you could send, if this applies to you and your agency, if you could send me an email telling me who the best contact person is who could supply that information, my intern will reach out and we'll work to update that and get that resource available to the officers as of January 1. So thanks.
May I ask, are you looking for more emergency kinds of services, like at that exact moment, or are you looking for larger?
I think it will be more of that exact moment, because with bond reform, there may be more people who aren't taken to jail, and so may need a referral more immediately.
Thank you. We'll move on to Systems of Care Grant discussion, item D on your agenda. We have somebody from Tri-West there.
Yeah, we have two individuals joining us virtually today. We have Lisa Tamaka and Jesse Seeger-Walls with us from Tri-West, obviously. They're going to be talking about a related item to youth and adolescent services in this community, also directly related to what Stephanie has shared with us today, and that's our Systems of Care Grant application. We submitted for this grant in April of this year. Is that correct? Yeah. And we did not receive funding for it, but we were pretty proud of our submission. And so we brought Tri-West in here today to talk a little bit about that submission and then how we might approach reapplying for the next time this funding comes around.
I'm going to share my screen, and I'm going to ask you to ignore the fact that you're going to see the slides on the side, and you'll probably see my notes to myself, so sorry about that. And good morning. Once I share my screen with you, I can't see you, so I'm doing this a little blind, so you'll have to hang in with me. I met most of you through either the last System of Care grant or the crisis, our crisis assessment. And given the time, what I want to do today is just kind of really quickly run through what we put in the last System of Care grant, kind of as a refresher. And I'm going to skim over most of it just to kind of get you guys thinking of what was there, touch base on what our challenges were, and then kind of give you some food for thought going forward. Because SAMHSA has, they periodically release what they call their forecasts. And so they are forecasting to release the System of Care Notice of Funding opportunity around the end of December. We don't know when the expected date will be in order to submit, but they anticipate awarding 18 system of care grants. So it's a much bigger number of grants that they're looking to award than it was last time. I think the last time it was smaller. I can't remember, but they awarded 6. So this is a bigger pool, and it opens up the door for additional opportunities for communities to be funded. So really quickly, we looked at kind of setting up a system of care children's team, and that team kind of fell under McLean County. And in discussing and putting this grant together, to kind of think through what that team would look like, what the system of care would look like, we literally met from March 20th through April 15th. So it was a really quick turnaround time. And I will say this, when Kevin talks about, kind of the success of getting this grant out the door, Tri-West worked with 3 different communities. You all were the only community who got to the finish line. The other 2 kind of disintegrated, for lack of a better word, still early in the morning, but they fell apart or couldn't come to a consensus on what they wanted to do and how they wanted to do it in time to be able to submit the grant. So I applaud you all for being able to do that. And what we did last year, I think, provides a phenomenal foundation for being able to move forward and think about what to do in this next coming year. You have the Behavioral Health Coordinating Council, and that was going to establish your system of care team to oversee your grant. And we set an overarching goal of the system of care team to create an integrated, holistic system of care that ensures all youth enter adulthood happy, healthy, and productive. Got a set of slides with your system of care goals. We had a total of 6. The first one really is around that governance structure, because that's an important required structure within your system of care grants. And so it's really to enhance and sustain coordination between your child serving agencies and creating your system of care team. That also, as part of a system of care grant, you're required to have 2 key personnel, and that are your program director and your lead family coordinator. So this is all about getting in place that program director, that lead family coordinator, establishing that team, thinking about what the charter, mission, vision would be, as well as the responsibility of all of the members, and then reporting quarterly to the BHCC, developing an annual training plan, and really working to develop a sustainability plan by year 3. Because if you all remember, the system of care grant is a 4-year grant, and it is called a system of care expansion and sustainability grant. So they really do want you to be working towards putting in place the infrastructure that will sustain this when system of care funding ends. We looked at, and I didn't put it in all of the slides, but I'm going to state it now. We really focused on, for most of these goals and objectives, that underinsured population. But I realized as I was putting the slides together, if I put in the words un and underinsured, then the slides got really small. So recognize that we really did think about the fact that Pathways for Success was coming down the pipeline, and that the challenge was often serving those children, youth, and families that kind of fell between those gaps. So in thinking about care coordination, it was really targeting decreasing behavioral health crises and the need for more restrictive levels of care by increasing the community's capacity to provide that care coordination and wraparound. And really looking here at supporting your community, like supporting community-wide adoption of high fidelity wraparound and intensive care coordination, thinking about the availability of those flexible funds to children and youth and families that don't fall within the Medicaid population, and then working with SAS, mobile crisis, and other providers to really support about 80% of the children and youth referred to these services and supports, but really ensuring that we keep them in their homes. on to the next slide. We looked at, of course, your intensive home and community-based services. And in the grant, we talked about intensive home and community-based services, really including school services and supports within the school. That falls under that community piece. And it's improving the clinical outcomes for children and youth in McLean County through the provision of those intensive stabilization and home and community-based services. And the goal was to establish intensive stabilization and home and community-based services in a way that promoted, of course, your culturally, linguistically appropriate, trauma-informed, evidence-based models, but supporting community-wide adoption and promoting the use of a shared language, as well as increasing your family and peer support. Under Goal 4, we looked at your school-based services. And for this one, we talked about screening children and youth in McLean County's districts for mental health, and by being able to identify them, then referring them to the appropriate services and support. So we're looking at your districts adopting a universal screener. And so as part of this, we talked about establishing a universal screener implementation team, because we realized that it was very important to have something in place to guide this process, because you weren't going to go out and just say, hey, we're going to roll out the screener districts, here you go. But looking at what your recommended screeners are, rolling it out one district at a time, one district every 12 months, with the expectation that by the end of 18 months, that district would then have adopted that screener and moved it to full implementation. And then partnering with the system of care team to establish metrics for data collection and evaluate the data that's being collected, and using that information to really look at what are the needs of the children and youth in McLean County, and then developing services and supports based on that. We looked at, of course, increasing family and youth voice. That goes to hiring that lead family coordinator that is part of the key personnel within the system of care grant. But it also looks at establishing and supporting a family and youth advisory committee. And that family and youth advisory committee would work with the system of care team. And as part of this goal, we also recognize the need to be able to provide some support and training to your family and youth advisory committee members. So we wrote in kind of looking at providing them with a minimum of 2 leadership activities per year, because we recognize that they're not necessarily coming to the table with these leadership skills or advocacy skills at that.
Hey, Lisa, it looks like your audio might have cut out there. I'm sorry. Can you hear us? It looks like she can't hear us either. Jesse, can you hear us?
Mental health advanced
there we go.
practitioner. I somehow or another I lost. Okay, am I back?
Yeah, we're back now. Sorry,
Okay.
Lisa.
No, it was me, because I lost mouse, I lost keyboard, I lost everything. So something happened over here. There's gremlins in my system. So 6 is access to psychiatric care. So we're looking at expanding that access and expanding face-to-face telehealth services to children and youth in the clinics, at schools, and in the community. Our proposed targets, we're looking at a total of 430 youth across the 4 years of the grant. That's how we broke it out. I'm moving quick, so just hang on. Here are just some of my thoughts about the 2022 proposal. We did this in a short timeline. We navigated it between the Open Meetings Act. So we'd meet with part of the group one day, part of the group the next day, bring things together. Match is always a challenge. And I'm certain that there were some other challenges, being that this is the first grant. Just so that you know, kind of talking about who was awarded. It was split between counties and states. And what they were awarded for was really your mental health first aid, zero suicide, health equity, rural system of care. And then one community looked at early intervention, that 0 to 6 age, and being able to identify children and youth with SED early. They have had several other system of care grants, so that was building on those services and supports for their rural communities. Then three of them were awarded for either mobile response and stabilization services, and one called it family response and stabilization services. So what I want to leave you all with is, do the services and supports outlined in the goals and objectives still meet the needs of the children and youth in McLean County? And what would you change? And here are some things that I think are food for thought. You know, and I made a lot of notes as we were going through the meeting today as well. So you'll see those on the bottom, and I'll send my notes out to Kevin so he'll have them as well. So as you think about this, like, is there an opportunity to strengthen the current crisis system, including supporting the implementation of the triage system? What would this look like? Do you want to continue filling in the gaps of intensive services for families that are not eligible for pathways, or build on the pathways infrastructure? Do you want to build community capacity to deliver the services and supports needed by the care coordination and support organization? Do you want to build in supports to help students transition from the Bridge Academy back to their schools, training for community providers, connecting the dots between your community services? It's a list, but I think there are things to chew through. Here is kind of my last slide in this barrage of slides. When thinking about planning for 2023, I threw this out here just to kind of get you all thinking, because we have a window of time. We expect that we'll see a notice of funding opportunity towards the end of December. My guess is it will be January. But historically, they've been due end of March, mid-April. Here is what I would suggest you consider, and then decide what makes sense for you in moving forward. Think about identifying a system of care grant core team, a set of individuals that falls under the number of the Open Meeting Act, so that they, by November, so that they can come together and convene kind of 4 planning groups from November to December 16th, figuring everybody falls off the end of the earth come the Christmas holidays. Then they will take kind of this draft of a system of care proposal and present it to the broader children's team, which then can be worked through the month of January. We have time to seek input from family and youth representatives, which would always look good in the application process. By February, we can kind of finalize those commitments, those match commitments, so the county and the community providers that are involved in this really kind of know and feel comfortable with what the budget is. Finalize the draft the draft proposal, including the budget, by March. Present the full proposal to the BHCC for input, and then you'll be ready to submit a full proposal. And it will feel like a very, hopefully, well orchestrated, non-stressful process to get this grant out the door if it's something you're considering doing. So that's kind of, and I'm going to stop presenting so that I can see you all, and then open it up for any questions, thoughts. I know we have a short amount of time, and so a lot of this is really just to kind of get this out here and get you all thinking, get you all remembering what we did, thinking about if you want to go forward and what you'd like to go forward doing, and then putting it, kind of getting your thoughts on a strategy to do that in a collaborative way that isn't, that doesn't feel incredibly stressful, or just the hurried rush of any grant writing experience. So I'll shut up and
Thank you very much, Lisa, for joining us today. We appreciate that. And thank you all for hanging around. I know this is running a little bit long today, but we very much do plan on reapplying. So Lisa proposed putting a timeline together to show you all today. I know that seems probably pretty quick. November 1st is right around the corner. But I'm happy to, jump in and get the party started on this as soon as possible, because I know the short timeline was something that really was a hindrance to us last time. And I think that we'll definitely get funding for this if we take our time with it and have the kind of group approach that we took last time. I think that they've laid out a good plan here. And so I'm hopeful that we'll have a good submission this time around again as well. And I'm curious what kind of input you guys have right now or questions for Lisa.
So Lisa, the grant is, the NOFO is expected in December. Do we have a sense of when the grant would become live? Is it the same time frame as the last one?
My guess is it's the same time frame as the last one, because the forecasted dates are very, very similar. So I'm assuming an August 28th, September 1 start. It's kind of what they've historically done. There's only a couple of examples where they've done it a little differently. And I don't expect the grant application to have any major changes to it. I looked back over the last several years, and truthfully, other than, either increasing an emphasis on like trauma-informed care or disparities, there isn't much change from year to year. So I think you have the opportunity to pre-plan and be ready.
So can we get a copy of that PowerPoint when she sends it to you? And then also, Kevin, is there any reason that particularly people that participated in that grant submission, can we get a copy of the grant itself or any of the comments that came back from the grant submission, just to be able to look that over?
Yeah, I actually wasn't involved in the initial submission for this, so I've been trying to reach out to ERA Commons and get the scoring back. But we're having some difficulty with that because I was not the person who submitted. So we're working on getting that information back. I do have a copy of the grant submission and all of the information that was used during that planning process, and I would be more than happy to share all of that with you. Sure.
Okay, Lisa, thank you. Jess, thank you very much. We'll get together and respond. Okay,
Thank you.
let's go on now to your part. Number 4, program initiative updates, Triage Center transition.
Yeah, so we officially passed our finalized contract through Executive Board for the transition of triage services to the Center for Human Services starting on November 1st. As an update to that, those existing triage services will stay where they're currently at through the end of this year in that physical location. I'm in the process of working with Clinical Director Kim Fryman to sort out our current staff, who will be, a lot of them might be transitioning over to CHS, and kind of working through the specifics of how triage works and any potential changes that they might implement when their construction project is done on the new location, hopefully around January 1st of this upcoming year.
Now, isn't that going to be located below the tower?
Yeah, it's going to be located about, what direction are we going here? About
North.
Is that three blocks? Yeah, north. Yeah.
3 blocks west, 3 blocks north.
Yeah, I haven't had an opportunity to see the site yet, but they've told me that that's where they plan on locating it, and we have money that's allocated for that in the contract specifically for construction on that site. Any questions on that?
Questions or follow-up?
Okay.
Okay, thank you. And let's talk a little bit about the forum. You'd like to open up a discussion
Yeah,
on
so
that?
thank you all
Any
again to everyone
impressions?
that participated in the Behavioral Health Forum this year. We had a little over 300 individuals in attendance, which we think is a pretty great success considering this is our first time returning to an in-person event in several years. We have started to receive some feedback, so if you have not completed a form and you were in attendance, we would love to hear your opinions about the event and some of the things that we could do differently next year to continue to grow and make this a great community event. Some of the feedback that we've seen so far, we tried to put together to relate to all of you now, and some of that was offering same sessions at different times, inviting more Unit 5 and District 87 staff. I would say in general, for our Behavioral Health Forum, we've tried to get more of the community members' involvement, to get more student involvement, and that's something that we definitely want to make a concerted effort for in the future, is attracting those populations of individuals. We've done a consistent and great job of getting professionals in this community to show up, and I know that CEU's made that, even more appetizing to show up on that day. But really connecting with more of the community and students is something that I think we're going to take a greater focus on moving into this next year. One of the other recommendations was creating a resource fair map, and then also offering referral forms for professionals there. And then one of the other ones I saw consistently was that the venue was very cold. I don't know if anyone can speak. Okay. I was running around sweating the whole time, so it didn't even register with me at all. So that's something to definitely take note of if we work with the Marriott again next year. Any questions or suggestions about the forum this year? Any feedback you could provide at this time? Okay, thank you.
I was kind of wondering about the outreach to leaders in the education systems, how much they were involved or how much more we could get them involved in contacting them. I know there were some professionals from different systems that come, but we have to identify the mission and look at the mission for what we had originally written in the plan. Was maybe to provide more awareness to the community at large. And so we need to take a look at that and see what else we can do. We tried students once. It's a bad time for students, that time of the week, unless there's people from the schools that are involved with bringing them as a group. And then you have to tailor-make your sessions for those types of things too, because you people involved with youth all the time understand that. So some things we can look at and see if we can expand it. 300 is a great turnout of people that are involved, but what about the people who we want to still be making aware of what we can provide and, just in general, the general awareness for mental health. So something to think about, okay?
Sure.
Anything else today?
That's it for me.
Okay, our next meeting is December 9th, coming up, 7:30 again. I may be talking to some of you about having a roundtable discussing between now and then, if possible. And that's all we have, and thank you very much for coming. Anybody else have anything to add? New business? We'll talk to Trish and more and see what we can do about the systems of care. Okay?